significance. Now we will talk about galactose metabolism. So significance of galactose, you can see this is the very similar to hereditary fructose intolerance. You can see the disorder where we will see here will be very similar to fructose intolerance, and that is why this class is very easy. It will be very easy because and we have already laid the background for this class in bone diaphragm disease. Everything matches with that. There is a little bit difference, but these all match with this glycogen storage disease. So you can see galactose are very important. We have seen galactosyl is galactosyl ceramide. You know it forms the main lipid of myelin sheath. First, sulfogalactosyl and galactosyl ceramide will form main lipid of myelin. So galactose is helpful in formation of myelin. Galactose is very important for blood group formation. Blood group B, group A, all blood grouping. It is because of, you can see here the difference in blood group A and B. You can see here. Here this is galactose. Round figure is galactose here. So this is galactose here. So here this is also galactose. So this is galactose is present in both. Galactose is present here in blood group B, and blood group A. What is it? Galactosamine. You can see galactosamine is present in blood group A. Amine is present. You can see A for amine, galactosamine. Galactose for blood group all. Differentiating, if you remember galactose, you will remember the difference between blood group. So blood group B will have galactose, and this blood group A has A for amine, and blood group O has 0 galactose side chain. So that is how you can remember. I remember this way. Okay. And in between, this is a trisaccharide here. This is fucose. So trisaccharide with fucose, this is tetrasaccharide, like arrow-like thing. You can remember arrow-like thing with. So you can easily remember this. Galactose, glucose, this type of, if you remember. So it is O. To O, if you add this amine, galactosamine, it becomes A. If you add plain galactose, it becomes B. So this is the simple difference makes this ABO group. There is only difference. There is no difference in protein. Only difference in this polysaccharide. That is why polysaccharide become very important. Glycan part of this glycoprotein becomes very important. This is the difference between ABO antigen. So in that way, I am also teaching you ABO antigen, which is a VVI part of your USMLE. Maybe you will study in your hematology. This is a very VVI for hematology. Just remember, don't ignore it. Okay, so galactose is actually the main carbohydrate that differentiate this ABO blood grouping. And dermatan sulfate. Dermatan sulfate, we have seen dermatan sulfate has galactosamine and then glucuronic acid like that. So this galactose is part of this dermatan sulfate. Now lactose, you see, lactose is the main source of galactose. Lactose is the main source of galactose. So we will see here the metabolism. As I have told you, this galactose and glucose convert into each other. Not galactose directly cannot convert into glucose. So UDP galactose will convert into UDP glucose, each other like this. UDP glucose by a reversible reaction that is called epimerase. Galactose epimerase. You can say GAL enzyme. Okay, UDP galactose epimerase. So this epimerase enzyme converts into each other. Now, in order to convert this, when you take galactose, when somebody takes galactose or baby takes galactose, galactose has to be converted into galactose 1-phosphate to convert this into UDP galactose. As we have already seen the same type of reaction in glucose metabolism. During glycogen synthesis, glucose has to convert into glucose 1-phosphate, and this glucose 1-phosphate will be transferred. The same type of enzyme, uridyl transferase here, galactose uridyl transferase, GALT, will add UDP. It will convert this, and this can be converted to each other. Isn't it very simple metabolism? If you remember the metabolism of this resembles the part of glycogen metabolism, get glycogen synthesis, and this is the actually epimerase enzyme. That is what you have to remember. Will you able to remember? Are you able to correlate this with glycogen synthesis?
Yes, sir.
Okay, thank you. Now you will see here why our bodies need to synthesize galactose, UDP galactose, because UDP galactose can be utilized to synthesize lactose. So even a mother takes directly galactose, so lactose will be synthesized, or from glucose. UDP glucose will convert galactose, and galactose will convert into this. Glucose can convert this way into lactose in mammary gland, in mammals, in human beings. So this is how lactose is formed. This is normal lactose formation pathway. Now, if there is any problem along the pathway, this is the pathway will not be, the galactose will not be metabolized anywhere. Even galactokinase is problem. So what happens is the same way we have seen. Aldose reductase is present in which all tissue? Renal tissue, retinal tissue, neurons, and then what else? Lens. So these all tissue have only aldose reductase. So aldose reductase would there also, if somebody takes very high amount of galactose will convert into galactositol if there is no metabolism, and this will be causing pathogenesis. This will be causing damage to nerve cell, renal tissue, retina, the same way we have seen in polyol pathway. Galactotitol, galacticol. This is also a polyol like sorbitol. Now, so this is the one pathogenesis, cause of pathogenesis when any of this enzyme is absent. And if this enzyme is absent, this will also be the cause of pathogenesis. High galactose will cause the pathogenesis. Unfortunately, this enzyme is the main enzyme you have to remember. Here also transferase, uridyl transferase is the main enzyme, because of deficiency of that main problem arises, and this is the most common among the disorders of galactose metabolism. So let's see. You already know this. Pyrophosphatase, you already know this mechanism. So I don't think I should talk about this. Okay, so leave it. So you can go and study yourself. So this, see, same slide actually, same slide. So I don't want to waste time. An infant born 22-year-old female experiences lethargy, vomiting, jaundice, the same problem we've seen in hereditary fructose intolerance. Soon after birth, you can imagine 6 months when the baby is exposed to fructose. So this is a very big difference. See, this is a very big difference, because baby is exposed to lactose and galactose just after birth. So soon after birth, that is where the problem is, soon after birth. An infant is placed on galactose-free diet. When the infant is placed on galactose-free diet, milk formula or some other diet, shows gradual improvement. So galactose is a problem here. Which of the following step in galactose metabolism is most likely impaired in this patient? Be quick to answer. Okay. So I'll answer. Okay. So as I've told you, here, because of this insolubility of this, when this accumulates in cell, it will cause more problem. Because this is soluble, even if this enzyme is not there, it can go out of the cell. Though there is in some tissue, it will convert into galactitol, but it can also come out of the cell. This galactose will not be that toxic, but it is very toxic. And generally, enzyme deficiency happens. This enzyme is deficient. The transferase, GALT, will be deficient. Galactose uridyl transferase. Okay, so GALT will be deficient. So this is the region. So this is, you can see here, the 3 types of disorder. You can see galactose 1 phosphate uridyl transferase. This is the most common, and that is why this is a classical galactosemia, type 2 and type 3. Type 2 is because of deficiency of this first enzyme. Type 2 is because of deficiency of this enzyme. Okay, and type 3 is because of deficiency of other enzyme. You can see this epimerase enzyme. So type 2 and type 3. Type 2 is galactokinase. This is it will go out of the tissue. So permeable, that is why it will not cause much problem. So this is type 2 galactosemia is fewer medical problems with class than affected infants develop cataract because of, you know why? Because of galactitol, galacticol. Because of this aldol, only cataract is the problem. You understood why cataract? Why cataract? Because this is, if this is kinase is not there, so it will convert into this, and that is why this cataract. Otherwise, no long-term problem. So you can, and you understood the pathogenesis of this. Here, this can actually, this enzyme deficiency, the last enzyme deficiency, can have mild to more severe condition, and these are the conditions: cataract, delayed growth, development, similar to this. Okay, similar to this. It can have similar to this and this. Okay, in between this and this. Type 3 has between this and this, but these are type 2 and type 3 are very rare. So you can already understand milk intolerance. So why milk intolerance? Because of not non-metabolism of this galactose. Poor feeding, galactose is not metabolized, failure to thrive, jaundice, hypoglycemia. You know why jaundice, why hypoglycemia? Again, the galactose 6 phosphate will inhibit. You can see the similar to glucose 6. Here galactose is very similar to glucose 6 phosphate. You can remember. So say similar to this one Garrett disease, it inhibits whole pathway of synthesis of this breakdown of this glycogen, and then gluconeogenesis also will be inhibited. That is why hypoglycemia, and hypoglycemia will lead to jaundice, dry skin. Okay, so these are the presentation you can see, and you know galactitol. So this will be accumulated in this tissue where aldol reductase is only present, and this will cause the problem in this tissue, damage to this tissue. So neuropathy, kidney damage, lens damage, these are the problem also associated. And hepatomegaly, because of this galactose 1 phosphate will be accumulated in hepatocyte. The same way it is accumulated in von Garrett disease, and glycogen is also accumulated here, and that is why hepatomegaly, poor muscle tone, glycogen degradation also will be problem in your skeletal muscle. That is why hepatomegaly, poor tone, elevated liver enzymes, liver damage will lead to this. So total bilirubin rises because of lytic anemia, because of this hemolytic anemia also. Serum galactose is high, galactose 1 phosphate level will actually be high because of enzyme is deficient to that metabolize. This treatment is elimination of galactose, lactose containing compounds. You eliminate and remove. Here in this condition, diagnosis means treatment. So severe mental retardation, if it is not treated because of, you know, because of this pathogenesis, lack of blood glucose, and then because of neuropathy and all, severe mental retardation, and this liver disease, infantile cataract. So you know why cataract happens in such patients. So these are the problem you will see. So why is hepatomegaly present in untreated cases? So you can see the answer. Why is hypoglycemia present? You can see the answer. Now this is the patient. You can see the patient. You can see this baby. Hepatomegaly, renal failure, brain damage, cataract, everything will happen in such patient.